Thanks very much for the opportunity to present today. I'd like to start with an acknowledgement of country. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land that I am presenting from. I pay my deepest respect to elders past, present and emerging. This is an overview of my talk today. First, I'll set the scene. I'll talk a bit about what chronic kidney disease is. We'll talk about the various renal replacement treatments and a brief comment about antibiotics for kidney tract infections. So in terms of setting the scene, it's useful to characterise who are patients with kidney disease. So in general, kidney disease is defined as a decrease in GFR, and that decrease in GFR may be due to acute kidney injury where creatinine changes and varies, or chronic kidney disease whereby the creatinine is elevated and remains elevated and usually deteriorates over a period of years. Due to interests of time, I won't talk much about acute kidney injury and mostly will be about chronic kidney disease. Patients with advanced chronic kidney disease receive various kidney replacement treatments, of which are shown here, and we'll be talking about each of those as we go through. So why is it important to talk about antibiotics in kidney disease? Well, there's a few reasons. First of all, patients with kidney disease have frequent interactions with the healthcare system, and therefore they're prone to or colonised by multi-resistant organisms. So this prompts optimal antibiotic prescribing. Secondly, patients with kidney disease have a predisposition to infection, and therefore antibiotic usage is common. This is because they have frequent vascular access, other indwelling devices, and they have a degree of immunosuppression. And because of kidney disease and impacts on clearance, this causes a change in drug disposition, and therefore we need to change the dosing that patients receive of antibiotics. And so we need to make sure that we make all dose adjustments that are appropriate. As we know, inappropriate dose adjustment can cause adverse events. If we don't decrease the dose enough, then someone can develop toxicity. If the dose is too low, then we have treatment failure. And this is a particular issue with antibiotics. So we need to be appropriately dose adjusting. And so this means that we're in a position where we need to consider both the drug and the patient when we're prescribing. Now, I know that we do this all the time, but in the context of the drug with an antibiotic, we need to get to an effective concentration as soon as possible. We know time to antibiotics is an important outcome or variable for outcomes from treating with infections. But when thinking about the patient, we need to think about who they are, and that relates to both their GFR and or kidney related treatments. And these are all embodied in the principles of personalised medicine, whereby prescribing decisions that we make are relevant to that person. So let's review what is clearance. So clearance determines a maintenance dose, and this is obviously very important. Clearance is altered in patients with kidney disease. So this formula shows us how we work out what is total clearance. It's a sum of the kidney clearance, the liver clearance, and other clearance. We know that kidney clearance decreases in patients with kidney disease, therefore decreasing total clearance. But when we give certain treatments, for example, a kidney replacement therapy, this can actually cause an increase in the other clearance. This clearance may vary at different times. For example, with intermittent dialysis, it's on sometimes, it's off most of the time, in which case this can only have only a small impact on the overall clearance in, for example, 24 hours, but at a particular time it can be a significant change in clearance. And we'll be talking about that as the talk goes through. And so changes to the maintenance dose depends on the extent that the total clearance decreases compared to the healthy population. These same principles are shown here graphically in case you're more interested in pictures than words. We can see here three different profiles for three different types of drugs. For example, if we start with the red line, we can see that as creatinine clearance decreases, so too is drug clearance, and it's all fairly proportional. So a 50% decrease in kidney function would lead to a 50% decrease in drug clearance, and so would have a 50% decrease in the dose. If we compare that to macrolides, which are mostly hepatically cleared, there's this fairly straight line, and therefore that dose doesn't change much with kidney function. And then if we look at ciprofloxacin, for example, like most fluoroquinolones, they're a mixture of both renal and non-renal clearances. So changes in the kidney function can have differing impacts on the dosage of drugs depending on the proportion that is cleared by the kidneys. In general, a 50% decrease in clearance prompts dose adjustment. And the usual ways that we can adjust the dosing regimen is one or two. We can give the same dose but double the dosing interval, or we can halve the dose at the usual frequency. So when thinking about prescribing of antibiotics, the aim, of course, is to maximise the effect of limit toxicity. We've already discussed that. And to do this requires knowledge on the antibiotic pharmacodynamics and pharmacokinetics. And there's two components to a regimen. The first is a loading or initial dose, and the second is a maintenance dose. The concentration time curve should reflect the kill characteristics of that antibiotic. This is an example of what happens with the loading dose. By giving a loading dose, the concentration goes straight into the therapeutic concentration. Of course, you need to know the right loading dose to give and make sure it's correct. If we contrast that to a drug which takes time to get to steady state, it means that we get an effective antibiotic concentration very soon. In general, the loading dose does not change in patients with kidney disease. We would normally give the usual loading dose to patients. It's the maintenance doses that would change. These are kill curves, which identify or describe how antibiotics, the factors of the antibiotics which impact on the kill of bacteria. We don't have time to go through this in detail, but I think it's something that's familiar to you. But the point I wanted to show here is this concentration time profile of a drug should largely relate to what is the main determinant of kill for that antibiotic. There are a number of general suggestions that are put around for how we prescribe a drug to someone with kidney disease. The first suggestion is just start with the average dose for the population and titrate up or down depending on clinical response. This may sometimes work with patients with kidney disease. If we're prescribing a drug that has a wide therapeutic index, or particularly if it's for a short duration of time, or if we're prescribing a prophylactic antibiotic, in which case the dose is already low, this is probably all right in many cases. At least it maximizes the likelihood that the person will receive a treatment, an effective treatment. If we contrast it to this other approach, which is the start low and go slow approach, whereby we start at a low dose and titrate up to clinical effect, clearly this doesn't work for people when we're prescribing antibiotics, because time to effective antibiotic concentration is so important for clinical outcomes. And therefore that doesn't work. So let's talk about chronic kidney disease. So prescribing of antibiotics to patients with chronic disease is very important to discuss because it's a very common clinical scenario. There are a wide range of antibiotics, and as I've shown you, they're impacted to a different extent by change in kidney function, and patients have a wide range of GFRs. Fortunately, there are many dosing guidelines that exist, and we can rely on these to have some guidance. It is useful to note, though, that many are frequently based on limited data. And they do not necessarily account for inter-individual variability, some of which is unpredictable. A guideline is a guideline. This is an example of a prescribing guideline from the ETG, which, as you know, we use a lot in Australia, therapeutic guidelines. And I've chosen here to look at cefepime. Cefepime is important because it has neurotoxicity if we overdose someone. The concentration when it's that high can cause confusion and seizures. Note that it mentions that a loading dose may be required, although it doesn't actually give instructions as to how that loading dose should be given or when. It mentions a dosage adjustment is based on GFR, and as GFR decreases, there is a change in the dose. Similarly, as different methods of dialysis are introduced, so changes the dose. I think the question that's on here is, what is the GFR? How do we ascertain the GFR in an individual? There are a number of different ways that we can do this. The most common that we use are these methods which are based on a serum creatinine concentration. There's our friend the Cockcroft-Gault formula that was developed in 1976. It's often called the E-creatinine clearance, estimated creatinine clearance, because it was validated against a 24-hour urine collection. It gives you a measurement in mils per minute. And some of the controversy that relates to this is what body weight do we use? Actual body weight, ideal body weight, adjusted ideal body weight. The next one is CKD-EPI, which was developed in 2009. This is the automated eGFR, the one that we'd get on a computer system. All of these measurements are indexed to 1.73 meters squared. That means that if you have a patient which has a body surface area higher than 1.73 meters squared, then their actual GFR is going to be higher than that, what the computer is giving you. And so we can de-index this eGFR to give the actual GFR, or to estimate the actual GFR in that patient, by multiplying the patient's eGFR by the patient's body surface area and then dividing by 1.73. We can also measure the creatinine clearance using a 24-hour urine collection. I'm really sorry about the sirens in the background. There seems to be a fire issue. We can measure the creatinine clearance using a 24-hour urine collection, but this is unhelpful when we're prescribing antibiotics because it's unreliable and it takes too long for the result to come back. And there's other more fancy and technical methods of measuring, which we won't talk about today because they have limited relevance to prescribing of antibiotics in your average patient. So just to show how these different methods can give very different estimates of our GFR, let's talk about this case. It's a real patient, 42-year-old man, shorter than me, 1.75 meters tall, heavier than me, 132 kilos, with a BMI of 43, BSA of 2.5 meters squared. He has CKD. His creatinine is 300 micromoles per litre. If we were staging him for CKD, whereby all of the GFRs are indexed to BSA, then his GFR would be somewhere between 19 and 36. But if we wanted to know his actual GFR for the purpose of drug dosing, then it could vary anywhere between 27 and 53 mils per minute, depending on which method we use. In this case, this would be considered the gold standard. This is a measured GFR. And we can see here that the de-indexed GFR was fairly close. But similarly, if we used an ideal body weight, for example, or we can see that that would also be fairly similar when we use the E-creatinine clearance or Cockcroft Gold. So depending on how we use those different formulas, we can get very different measurements. And so when we go back to that example of cefepime, we could have very different approaches to dosing. Ultimately, neither of these are perfect measures of the true GFR. This is a table that we put together in a publication where we compared E-creatinine clearance and eGFR when thinking about which of these two formulas should you use in a patient. And in general, they are probably very similar. Where the main issues arise is when you've got obesity. For example, we said this is a weight more than 120 kilos. Then with the E-creatinine clearance, Cockcroft Gold, we should use the adjusted ideal body weight. For those same patients who are obese, for the eGFR, then we should de-index the eGFR so that it's more accurate. Similarly, when people are underweight, we should use the actual body weight, and we should also, for Cockcroft Gold, and we should de-index the eGFR. What about intermittent hemodialysis? I know this is a very busy slide, but work with me on this one. At the top, we can see a whole range of different dialysis modalities that are used. We can see here they all vary in blood flow, dialysate flow, ultrafiltration, and duration. The main thing to draw your attention to here is the urea clearance. Remember that urea is a water-soluble compound and it's readily dialysable. What we can see here is that the clearance of urea is quite variable between all these different methods of dialysis, depending on which one is used. This one, intermittent dialysis and intermittent hemodiafiltration, are the methods that maximize urea clearance, and therefore it's anticipated they'll also maximize antibiotic removal compared to these others, which would remove it to a lesser extent. Of course, there is a time factor here. This is a short dialysis, so it will be a short, strong impact, whereas this is a longer dialysis, therefore it may have lasting effect. So what is the impact of hemodialysis on drug dosing? First of all, we can get an increase in drug clearance, and I showed you that before. That was the clearance other. And that extent of that depends on the dialysis modality. As I just showed you, different modalities have different degrees of urea removal, and the same applies to antibiotics. But also it relates to the drug, its properties, but particularly the timing of drug administration. In general, it's much easier to administer a drug outside of dialysis because then we don't have to worry about the impact of dialysis. And for intermittent dialysis, this is quite easy because people are generally only having short runs of dialysis compared to the time after a whole week. Vancomycin is a really important drug, I think, to reflect on when we're thinking about hemodialysis. Many units around the world use a fixed dosing regimen. For example, everyone gets 1 gram, and once the level is less than 15 milligrams per litre, give another gram. Loading doses are prescribed inconsistently or are actually absent. So this is important because when we look at retrospective studies, we can see that many patients who are on dialysis receiving vancomycin are failing treatment. So the guidelines from America for the dosing of vancomycin were updated only last year. And they've given some very specific guidance in terms of how vancomycin should be prescribed. And we can see here that there's two factors to consider. When do you give vancomycin? Is it after dialysis or during dialysis? Noting that vancomycin can be removed dialysis. And what sort of dialysis filter are you using? Low permeability to high permeability. And both of these factors impact on what is the loading dose and what is the maintenance dose in different circumstances. So it adds some complexity to the dosing, but all with the aim of improving the achievement of therapeutic concentrations. But it's important to remember that these are still just guidelines. There is still inter-individual variability in, for example, the clearance of vancomycin during dialysis. This is showing plasma clearance, and each of these is a particular sampling point. We can see there's a lot of variability, which means that some patients with high clearance will have low vancomycin concentrations, some with lower clearances will have high vancomycin concentrations and be at risk of toxicity. So just because we use a more precise or more directed guideline, it doesn't remove the requirement for doing therapeutic drug monitoring. Unfortunately, though, guidelines with this much detail aren't available in most antibiotics. And that's also related in part to the fact that there's a lack of data to inform guideline development. So I really do believe that TDM has a very important role for drug dosing in patients on dialysis. Dialysis isn't always the enemy. Sometimes it can be helpful. Let's consider gentamicin. We discussed earlier about kill characteristics, and gentamicin is an example of a drug whereby we want a very high concentration relative to the minimum inhibitory concentration. We know that gentamicin is a cheap drug. It's got good gram-negative coverage. And it's bactericidal, so it's actually a great antibiotic to use if possible, but it's renally eliminated, so it accumulates in patients with end-stage kidney disease. We can see here that administration of gentamicin before dialysis allows for a high concentration, and then because the drug is removed by dialysis, it drops down fairly rapidly to a low toxic level. This allows us to give a dose of gentamicin, getting some of the benefits without having the risks. If we compare that to, for example, gentamicin given after dialysis at a full dose, which would clearly be associated with a higher risk, or even this more common practice of giving a small amount of gentamicin after dialysis, whereby we don't even achieve a very high Cmax, the red line looks like it's much more favourable. What about peritoneal dialysis? In those of you who aren't familiar with peritoneal dialysis, here's a picture. Someone has a catheter which goes into their peritoneal space. Fluid here is put into that space where it sits there, and that equilibrates with the blood and removes uremic toxins. Then that fluid is drained out. Unfortunately, PD peritonitis is common in people who receive peritoneal dialysis, and therefore they will need antibiotics. Antibiotics are usually given intraperitoneally, so we'll add the antibiotics in here so it goes into the intraperitoneal space. And the benefit of that is that it maximizes the concentration of the antibiotic at the site of infection. Antibiotics can also leave this space and go into the blood. You can measure the concentration of the antibiotics in the systemic circulation. And what causes the concentration in the systemic circulation in the space here to go down? Well, both PD exchanges, so subsequent treatments with a new dialysis solution will drain away the antibiotic, but also residual renal function. We know that the residual renal function in patients on PD is much higher than that on dialysis, and in some cases this can be quite significant. Fortunately, PD, we have excellent guidelines, international guidelines called ISPD. They look roughly like this. Relates to in the short time frame between 0 to 6 hours, give these antibiotics, look to cover for gram positives, which for example is cephalosporin or vancomycin, and then to think about if you need any other coverage. Just to note, I'm showing you here the 2010 guidelines to demonstrate the fact that back then it was said that you could give either cefazolin or cefalothin at 15 milligrams per kilo once daily, and that was considered good practice. Just to show some of these principles and some of the complexity with this topic is this research which was completed in 2016. The dotted lines are the concentrations in the PD space, and we can see here that the concentrations are very high following an antibiotic dwell, but then once that's exchanged and then with subsequent dwells it decreases. For cefazolin, it comes down, but it still remains above the MIC for the duration of that dosing period. But cefalothin, it comes down to an undetectable amount. If we look at the solid lines, this is a concentration in the blood. Again, with cefazolin, it enters the blood at a high concentration, exceeding that of the MIC, and it remains above the MIC for the duration of the dosing interval. Whereas with cefalothin, it was below that. So this suggests a risk of therapeutic failure from cefalothin compared to cefazolin. In 2016, the ISPD guidelines were updated and cefalothin was removed as an option with cefazolin remaining. So what does this mean? Well, with PD, guidelines are still very useful. I follow them. But data regarding IP antibiotics are still evolving, as you can see here. IP antibiotics can possibly treat systemic infection too, but there is some uncertainty about whether or not the concentrations are high enough and remain high enough. And so I still believe that TDM should be used more often in patients receiving IP antibiotics. What about continuous kidney replacement therapies? Well, these are commonly used in the intensive care unit, and this is a site where we've got acute and dynamic changes in physiology. There is variable degrees of endogenous clearance due to acute kidney injury, and there's also variable degrees of clearance by continuous kidney replacement therapy. As I've shown you already, this depends on the modality that's being used. And there's significant uncertainty that the antibiotic concentrations are therapeutic in the absence of TDM. This figure relates to some research published in 2015, which shows how in a series of patients who are all on continuous renal replacement therapy with acute kidney injury, who are critically ill admitted to ICU, despite a doubling in dose, or a twofold difference in dose, we can see here that there is no clear separation in the concentration time profile. There's a lot of overlap. Different time profiles are seen in this graph. So this says to me that there is so much variability in critically ill patients that we really need to be doing TDM if we're going to be able to understand what the concentrations are. What about kidney transplant recipients? Well, kidney transplant recipients are at risk because they're immunosuppressed, and this means that they're susceptible to infection, but it also means that they have an impaired response to infection. The other thing about kidney transplant recipients is they have variable and sometimes fluctuating kidney function, and this complicates dose adjustment. So my advice on these patients is to dose according to the same principles as outlined for CKD. But one thing to be aware of is that creatinine-based dosing can be more error-prone in patients who have had a kidney transplant and other transplants due to proximal muscle wasting, which has been attributed to steroids and probably other causes as well. Just a last comment about antibiotics for the kidney tract infection. Thinking about the fact that we have an infection in the urinary tract means that we would want to prescribe an antibiotic for which the concentration will be relatively high in the urine so that we can make sure that we maximize the likelihood of treating that infection. To my knowledge, there's not a lot of information around about peak urine concentrations, but I think this was some interesting data which was presented, which looked at a range of different antibiotics given in oral dosing forms, and despite these peak serum concentrations, the concentrations in the urine were much higher and certainly far exceeded MICs. The reason for this is that all drug will be filtered to some extent at the glomerulus and will enter the filtrate. And then during the course through the nephron, there's a lot of water absorption, and the water absorption concentrates the antibiotic. So I think many antibiotics will reach the urine in sufficiently high concentrations. There are some drugs that we shouldn't use. For example, nitrofurantoin is relatively contraindicated for GFRs less than 30, in part because it may not get to a high enough concentration, but also because of accumulation. So in conclusion, patients with kidney disease frequently require antibiotics, and antibiotic dosing should be individualized based on the patient's GFR. We've discussed how you determine that, and also the kidney replacement therapies. There are limits in data, and this prompts more research and also ongoing updates to guidelines, and I've shown you some examples of that. And I believe that in patients with kidney disease, a TDM is a very important tool for optimizing antibiotic therapy.